Hi, this is Brian Kim. I'm going to share with you this case of a patient who had a secluded pupil. There was also a pupillary membrane, required iris hooks to retract the pupil, and there was a white cataract, so I had to put trypan blue in it. And then I noticed the patient had a very unstable floppy capsular bag requiring a CTR. But the reason I'm posting this video, and that is to highlight a very important concept and technique, and that is to keep your second instrument between the posterior capsule and the phaco tip. I see too many surgeons going to town, doing the Phaco on their last pieces, and then the PC comes forward, and then it breaks the bag. And if you do this, you will never have this problem. So you can see that this pupil is irregular, small, and scarred down to the lens. I'm going to use my corneal marker to help me center and size my rhexis. I'm using a cotton tip to turn the eye, and then I'm making my paracentesis incisions, again using the cotton tip to help me to be flat to the iris plane so I can get a nice corneal shelf, which will give me a self-sealing incision. I'm injecting some intracameral lidocaine, and as I do this, I'm trying to get underneath the pupillary edge. Again, using this blunt cannula is very safe, and you can see I was able to get under that edge right there. I'm pushing some more of that lidocaine, and I'm just kind of teasing, getting around that membrane, trying to separate the edge of the pupil from the anterior lens surface. With these dense lenses and secluded pupils, you just never know what you're going to be dealing with a capsular bag. And so I always prefer to place iris hooks in these situations. So you can see I'm putting in 4 paracentesis incisions. And I'm putting a paracentesis incision subincisionally now. You can see I'm putting the iris hook in, and you can see sometimes it's a little bit of a challenge to get that down, and that's because I made a fairly parallel incision to the iris plane. Once it gets in there, you can just turn that little stopper so that the hook points downward, and then you can hook the edge of the pupil. And so I'm putting in the 4th one. The 3rd one, I had a little bit of trouble passing it, and I think it's because, again, the angle. But I'm able to turn the hook downward using the stopper, and then I'm cinching it down on this 3rd one. And then the last one here, you can see I'm able to turn it in such a way that the hook is facing down, and then I retract all 4 hooks. I put some trypan blue in, but I can see that it's just kind of floating, suspended in the anterior chamber, and it's having a little bit of more trouble painting it. So just to be more efficient, I'll go ahead and put the bubble in, which helps push the trypan blue on the anterior lens surface. And then now I'm injecting my dispersive viscoelastic, and then I'm going to perform my triplanar corneal incision. I make a vertical groove, place the blade into the groove, and then I'm going to flatten it out, tunnel through the cornea, dive down, and that's the triplanar corneal incision. Once that incision is made, I'm going to put the 5th subincisional hook. I'm going to retract the stopper, put the hook in position, turn the stopper so that the hook is facing downward. Sometimes it takes a little bit of work to get it, and then once you turn it, you're able to retract it and then cinch it down. I'm going to use a cystotome because in these cases I don't trust the capsular bag. So I went ahead with the cystotome and started my rhexis. So far I don't see any indication of any capsular bag compromise, but I am always wary in these types of cases. I then switch to the forceps, and I'm going around circumferentially, trying to stay within my corneal marks to help me have a well-centered and sized rhexis. Because of the hooks, it's a little bit of a challenge to know the size of the rhexis, and so that's why the corneal markings are quite helpful in this situation. I remove the capsular bag and then burp a little viscoelastic. I do my capsular fornix hydrodissection technique, place the cannula out to the contralateral equator underneath the anterior capsule surface, point the tip downward, you get a nice fluid wave. I'm decompressing on the left side and I'm sweeping, and then I'm going to start trying to spin the lens from the right side. I'm trying to be very ginger with this bag because, again, I'm not sure if there is any loose or compromised capsular bag. I'm starting to spin the lens, and the lens is spinning quite easily. And then I start the Phaco, lift the phaco incision with the chopper with irrigation off to minimize Descemet's trauma. And then I begin the double chop. Place the chopper out to the equator, and then place the phaco tip vertically. Bring both instruments together to crush the lens in half. In this case, even though I got a good chop, I wasn't really fully confident it went all the way through. I went ahead and repeated the same maneuver. And so the move should have fractured the lens completely, but again, I'm not quite certain. I do the cross chop maneuver, placing the chopper out to the contralateral equator, pulling the chopper centrally toward the phaco tip, and that crushes the right heminucleus. So I'm using some vacuum to try to mobilize the lens pieces. You can see I got this one quadrant out, and then I try to get the other quadrant out. And so I'm able to get the quadrant out quite easily. So it wasn't adhesed. There wasn't any unfractured parts of the lens. This is just a sticky 2+ dense lens. So this is, again, one of those sticky lenses where the lens just doesn't want to come out of the bag despite being fully fractured. These are one of the most annoying types of lenses in my experience, because you have to try to grab the lenses and it can get quite frustrating. Now that I chopped the lens, I'm just bringing the phaco sleeve closer to the tip. When I did that initial chop, I wanted to get a good chop, and so I extended the sleeve. And now that we're done with that initial chop, I'm bringing that sleeve back down to help bring that irrigation port closer to the tip. I rotate the other heminucleus in front of me, place the chopper out to the equator, place the phaco tip deep in the bag, and then I crush that second heminucleus. You can see it's a nice chop maneuver. And then I'm doing another cross chop maneuver of this third quadrant. And I'm scissoring to make sure that the piece is completely fractured in half. I place the chopper out to the equator again, and I'm fracturing these quadrant into smaller pieces. As I'm removing the pieces here, and this is very important, I'm going to go ahead and mobilize this piece, and then I'm going to go around with the chopper and the phaco tip and crushing that lens piece. And utilizing the high vacuum, I want you to notice something very important here. I'm again placing the chopper around the lens piece, crushing the lens piece between the chopper and the phaco tip, doing this in multiple successive maneuvers and using pulses of ultrasonic energy. But look here, look right at the 12 o'clock position. You saw that? You can see that momentary clear view. And I don't know what that was, if I grabbed the bag or if it just evacuated epinuclear material. But luckily, everything was still okay. But look at how floppy the capsular bag is. It is bouncing around like a trampoline, just bouncing and bouncing and bouncing. And this is why you want to place the chopper out between the posterior capsule and the phaco tip. I turned this other quadrant in front of me, place the chopper out to the equator, and then crush that lens piece. Again, these maneuvers are not being used with any fluidics, no vacuum, no phaco, and so it's very safe to do the chop maneuvers, even in the situation of a very floppy bag. So again, you can see I'm using that high vacuum and ultrasonic energy to mobilize those lens pieces, and the bag is so floppy. And as you can see here, as I always do, when I'm removing the lens pieces with high vacuum, I'm always keeping that chopper deep in the bag to protect the posterior capsule. Now you can see here that there's a fragment that's stuck kind of in the subincisional space on the right side, rather than going after it with the phaco tip, which would be very dangerous in this setting. Again, there is no epinuclear material. There is no cushion to protect you from the posterior capsule. I'm using my chopper to manipulate the lens piece in front of me. By using the chopper, this is very safe and very controlled. You cannot rupture the posterior capsule doing it this way. Whereas if you stubbornly and frustratingly start to try to buzz it with vacuum, you are going to break the posterior capsule. I'm very confident that that can occur. Whereas with this technique, I'm confident it won't occur. I'm placing the chopper out to the equator again, and I'm fracturing this last quadrant in half. I'm very gingerly teasing and separating the lens pieces. Again, I'm using successive mechanical fracturing forces, placing the chopper out to the equator again, fracturing the lens piece in half between the chopper and the phaco tip. And again, I'm using just a little bit of vacuum to position the lens pieces, and then I'm placing the chopper around the lens piece, crushing it with the chopper and the phaco tip, and then emulsifying the lens pieces with high vacuum and ultrasonic energy. I don't know if you noticed there, but when I started to emulsify that lens piece, I moved it so that it was on top of that large mass of lens material. So that's another pearl. When you're about to emulsify the lens pieces, just emulsify when you actually have a cushion of lens material. If you still have a big bulky piece of lens material, phaco on top of that to create that barrier from the posterior capsule. So in this situation, when most of the lens material is removed, again, there's no epinuclear shell. You have this very floppy and unstable posterior capsule. You want to always keep some protection from the posterior capsule. So you can see I'm very carefully using high vacuum and a little bit of ultrasonic energy to slowly remove the lens pieces. You see there's about 2 different layers. There's a top layer and a bottom layer of lens material, and that's also good, and it provides a layer of protection between the phaco tip and the posterior capsule. You see I'm using some mechanical fracturing forces to crush the lens pieces into smaller pieces. And again, to remind you, whenever I do the chop maneuvers, I'm not using any fluidics. I'm not using vacuum or ultrasonic energy. And again, this is why this is very safe and very controlled, especially in this situation. So I grabbed a little bit of epinuclear material, but you can see there's hardly any epinucleus. You can see this bag is flopping around. I have a little bit of nucleus still. It was hiding in the subincisional space. And so you see what I'm going to do here. I'm actually injecting dispersive viscoelastic into the bag because, again, I don't trust the posterior capsule is not going to come forward. And as I do this, this allows the lens actually to come forward as well. And so now I'm crushing it using mechanical fracturing forces and then using high vacuum and ultrasonic energy with the chopper deep in the bag, and I was able to remove the lens completely. I'm going to push BSS through a cannula and then take the phaco tip out. But as I do this, look at the bag. It starts to collapse in front of me. And so you can see how unstable that bag is. I take the phaco tip out, I put the INA handpiece in, and I start to do my cortical removal. I start in that very weak area, right in that spot, but it's not pulling the zonule, so I'm very carefully peeling that back. But as soon as I get it, you can see the bag puckers up. Thankfully, that polymer tip is there, and it prevents me from having any capsular compromise. So I'm going subincisionally now, again using vacuum to remove the cortical material in the subincisional space. But take a look here. As I start to pay attention to the bag, right there is some capsular folds, and this just tells you how unstable the capsular bag is and kind of explains why the bag was flying forward during the phaco. And that's why when you have that post-occlusion surge, no matter how good the technology is, that post-occlusion surge in this setting of a very weak bag is going to cause the bag to come forward and cause posterior capsule rupture. So I like to insert the capsular tension ring myself. You can see the hook grabs the eyelet and goes in. I use the Sinskey to lift the incision, go in. This bag is fairly deep because of the weakness of the zonule. So I want to make sure that I hook the eyelet with the Sinskey, but make sure that it goes into the bag, not on top of the bag. And as I inject further, you see that I was able to loop the CTR around without causing any significant torsional stress on the capsular bag. I inject some cohesive viscoelastic in the bag and then deliver the single piece intraocular lens into the capsular bag. I want to use the viscoelastic cannula to make sure that the lens is completely in the bag and that both haptics are separated. And then I'm individually removing each of the iris hooks. You want to grab the hook on one side and then pull the stopper back with the other hand, twirl the hook off the iris, and then pull them out, which comes out fairly easily. And again, you want to be very ginger in these situations. You want to remove the viscoelastic, but you want to be aware of the weak capsular bag. You can see I have a very dense capsule plaque, which I did not try to perseverate on and try to remove. I'm pushing BSS, come out with the INA handpiece, and then I start to hydrate my incisions. So you can see in the cases where you have a very severe floppy capsular bag, But even if you didn't, if you have a cataract technique that doesn't leave an epinuclear shell, I think if you go straight from hydrodissection and then sculpting, cracking, and then you don't actually create a separate epinuclear shell, you are running the risk of using high vacuum and ultrasonic energy and not having protection from the posterior capsule. Always place your second instrument deep in the bag towards the posterior capsule while you're initiating high vacuum and phaco. If you do this, you will drastically reduce your risk of post-occlusion surge, which causes the posterior capsule to fly forward. As long as you have that chopper deep in the bag, even if you have post-occlusion surge, you will not rupture the posterior capsule. Using the chopper to protect the bag is very similar to wearing a seatbelt when you're driving. Most of the time you don't need a seatbelt, especially if you're not going to have an accident. But the one time you don't, and if you have an accident, you're in big trouble. And it's the same with this. If you place that chopper out, protecting the bag from the phaco tip, you are far less likely to rupture the posterior capsule with the phaco tip due to post-occlusion surge. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.